Hi, I'm Patrick Flaherty with bagmass.com, the only anesthesia career site where you can find jobs, articles, and scholarships. And today we're very fortunate to have Peter Nose with us from G2 Anesthesia. He's going to talk to us about evaluating an anesthesia practice if you're going to be joining a partnership. Peter, welcome.
Thanks, Patrick. It's good to see you again, and I'm happy to do this. Thanks for asking.
Of course. Just to give you guys a little bit of background, I was very fortunate to work with Peter a few years back, and one of the things I really loved about Peter was anytime you talked to him, you felt like you came away a little bit smarter and a little bit kinder also. One of my good buddies who used to always say, you go into a meeting with Peter, he talks about stuff, you ask him questions, and by the time I leave, I feel like I just had a session with Yoda. Just the knowledge and the wisdom is just spectacular. So you guys are really in for a special treat. To get us started, Peter, can you just give us a little background about your practice?
Sure. I've been with my current practice for now almost 30 years. It's actually kind of strange to say that, but it's been a great practice. It's in San Jose, California. It's a physician-only practice, and it's in San Jose, but we're kind of in the more suburban area between San Jose and Los Gatos, California. It's been a great career, great practice. Been able to work with some fantastic surgeons, great staff of nurses and surgical techs. So it's just been very rewarding. I've done a lot of leadership work for the group over the years, not just managing the group, but also doing a lot of recruiting. So I've got to meet a lot of new, fresh grads over the years. And so it's always been one of the refreshing aspects of running a practice is meeting new people, bringing in new ideas, new energy, new blood for the practice. I think it's really critical.
That's great. And we're talking about, new people. One of the things we really want to concentrate today when we're talking is, what are some things that people should be looking at when they're joining a new practice? And where would you start with this process?
So one of the things that is perhaps obvious, but maybe so obvious that people don't really think enough about it is just the location. I think location is so important for the practice. It's in my area, a lot of people like to come to the Bay Area, San Francisco Bay Area. It's a beautiful place. There are a lot of things to do here. There are a lot of resources at anyone's disposal, but it's expensive. And we've had people who have come here, have looked at the practice, and then realize, it's just way too expensive here. And I can't afford, you've got a great practice, they're great people, there's great culture. But I just can't afford to live here. We've even had people who have come and started with us only to recognize that it's just, it's not doable financially. So I think that's something that really you have to think long and hard about is this really a place where I or my family or my significant other and I can afford to live? That's really important. If you are going to move to an area, can you afford to live close to the hospital? Or is this a practice where people typically commute to the hospital? That may not sound like an important factor, but when you're taking call, it's important. And the closer you are to the hospital, the easier it is to take call from home. The closer you are to the hospital, the less stress you have. Wondering, it's like, well, it's 4 o'clock and I'm done with cases. I'm on call. Should I go home or should I stay at the hospital? These are considerations that you may not think about when you're interviewing for jobs and looking at practices, but when you're in the thick of it, it starts to weigh on you. And the more you're experiencing these anxieties, the more it weighs on you. So that's something to think about as well.
No, I think that's a great point. I think a lot of people, when they first take a job, they're all energetic. This is all great. I'm putting up this for a month or two, and then you start to get into 6 months, a year out in advance, and it's like, man, I wish I would have moved closer to the hospital, or just
so true.
Looked at something differently. Great points.
And then I think also there's a certain value in when you're living close to the hospital. That tends to mean that you're taking care of your own community. You're seeing your surgeon friends, you're seeing the nurses and other staff who work at the hospital in the community. You're taking care of them. And there's a value to that we often don't talk about or recognize. And so that's another consideration is is this a commuter hospital where basically it's just a job, or is it really a career where I feel like I'm an integral part of the community. I'm taking care of the community. The community appreciates and supports me and my practice.
No, that's another great point. Yeah, it's a talk about a commuter hospital. That's something I live. We work in DC, and fortunately, a lot of us are commuting from the outside into DC, and we have a great time when we're there at work. And sometimes we get to hang out outside of work, a happy hour or something right afterwards. But it'd be nicer if we were all closer within that smaller community where, hey, we want to pop over for a hamburger or something over the weekend just to get together, because that really helps with the the group's dynamics and creating that culture of, hey, I want to help this guy out. Something's going on. Yeah, I can step up, as opposed to I'll catch you at work and that's the only time I'll ever see you. Really never get a chance to build those bonds.
Yeah, absolutely. In my practice, we are fortunate that many of us live close to where we work. And so just the other day, one of my partners commented on the fact that she had an appointment she had to get to in the afternoon, called for help. Somebody came in from home to help relieve her. And, because they live close by, they could do it. It was very easy. So, right, those little things matter, and they count a lot. They count a lot towards the culture of teamwork within the group. And I'll address that a little bit later, but I think culture is so important for practice.
Mm-hmm. Excellent. Now, we talked about the practice and the locations. What did you consider now, like the sort of the clinical picture of the practice at this stage?
Sure.
Or?
Yeah. So again, some obvious things are just, what types of cases would you be doing? Is this a trauma hospital where you're going to be doing trauma? Is it, does a hospital have a busy OB service? Is it just a hospital, or are there a number of surrounding ambulatory surgery centers? So, it's important to know what is it that you'd actually be doing clinically. Are the venues that are covered by the practice all within a tight, half-mile radius, or are they spread out over 10 miles? And does that mean you're going to be traveling to the hospital to start the morning, and then travel 10 miles away to another venue and go back and forth? Again, all doable, but in the stress of day-to-day practice, it starts to weigh on you if you're doing that every day. So just think about what is the practice like clinically? What kind of cases does the practice cover? Are you going to have access to all those cases? If there's a busy outpatient service, does that mean that everybody rotates and has access to those cases, or is it just a subgroup? If you're always doing it in the vascular room, doing the big craniotomies and vascular cases, it may seem like, I'd like to do a knee scope every now and then. So I think that, there should be some fair rationale for how cases are assigned. And I think that the fairest is if everybody gets to do everything, that means that the most people are going to be happy, with the exceptions of things like cardiac or pediatric. In my practice, we have a formal subgroup for cardiac and a subgroup for pediatric. And so all those people are board certified in those areas. And so they do take care of those types of cases. What's the call situation like? How much call will you be taking? Is it call from home, or is it in-house call? And how is the call assigned? Again, is the call assigned fairly, across the board, so that everybody helps cover the call responsibilities, or is it just, again, a subgroup? There should be some rationale that sounds fair. It may be that there may be like a senior track or some other reason that certain members of the group don't cover night and weekend call, but it should be fair and should be a policy that is ultimately available to everybody once they reach a certain age or reach certain criteria. Mm-hmm. So those are important things.
Now, are those we're talking about sort of some of the older anesthesiologists working where maybe they start taking less call? Is that something that's sort of written into the bylaws of the group so everybody knows what's going on, or is it more of just this is what we do when somebody hits a certain age or when they're starting to phase out?
So I think in the best circumstances, it's something that's actually written into policies for the practice. Okay. But every practice is different. Some practices don't have any written policies. Some practices just have kind of a gentleman's agreement, gentlewoman's agreement. so that for some of the older partners, they are relieved of certain more onerous duties. But I think in the best of circumstances, it's something that's formally written out and formally adopted by the group, so that everybody knows that at some point they're going to have those opportunities to benefit from different tracks.
Gotcha. So we talked about location. We sort of talked about the clinical picture. Let's talk about something that's really near and dear to my heart, because I've had to deal with this multiple times, unfortunately, in my short career, 14 years. I'm trying to catch up to you. Is how secure is the group with the practice? I mean, I was in a practice where we went from hospital employee to two different anesthesia management groups, back to hospital employees, to a hospital closing down, all within a time span of 10 years.
Yeah.
So is this something, how important is this when you bring this up in the conversation?
Patrick, you've lived kind of the spectrum of anesthesia practice experiences over your short career, and that's challenging. And I think that anesthesia groups are increasingly challenged across the nation, and that challenge is demonstrating your value to the hospital or whatever venue you're associated with, ambulatory surgery center. It's very easy for hospital owners and administrators to just look at anesthesia services as a commodity. Mm-hmm. It's assumed that you're going to provide good care, good, safe care. I just need to have that done at the lowest cost to me. And so it's really incumbent on the practice to demonstrate value to the hospital, more than just safely anesthetizing patients, waking them up, sending them home. And so it's, I think it's reasonable to ask potential practice, how do you make yourself indispensable to the hospital? What are you doing to demonstrate value? Is there something like a total joint program that you're integrally involved with, that you're able to demonstrate that the anesthetic care, the perioperative care that's provided by your group is actually contributing to shorter lengths of stay, reduced complications, higher patient satisfaction? Those are things that hospital administrators understand, appreciate, and are willing to pay for. But simply saying that we put patients to sleep, we wake them up, and they don't die is really, that's assumed, and that's not value that distinguishes you from any other practice. Most hospitals have some sort of internal survey, medical staff satisfaction surveys, where we as a medical staff will evaluate ourselves and other services within the hospital, as well as administrative services and things that the hospital's responsible for providing. And so how does the anesthesia department do in those surveys, relative to radiology, pathology, lab services? So it's reasonable to ask about performance there. And then, I think it's always good to see that there are members of the practice who have actually taken on leadership roles within the hospital, chief of staff positions, medical director positions for surgical services, other leadership positions that demonstrate that the anesthesiologist and the anesthesia department have been recognized for more than just their clinical care, have been recognized as contributors to the efficient production of good healthcare within the hospital. So I think that all those things help you get a better picture of how integrally involved the practice is with the hospital, and how the hospital in turn values the practice.
Well, talking about value, and this reminds me again about my hospital closing, is I guess another big question you want to start thinking about is, how's this group paid, and what are you looking for there?
Sure. So ultimately it comes down to the dollars and cents of how does the money come in for the practice. For most practices, the bulk of the money is professional fees. That is, we take care of patients, we send out bills to insurance companies, we get paid for that services provided. So those are the professional fee income. That's a large chunk of most practices, but recognizing that that's often not sufficient to pay for the number of staff that the hospital is requesting. or demanding for coverage, the hospital often will provide a stipend to make up for the shortfall between the cost of all the staff, all the anesthesia staff, and the income that's brought in solely by professional fees. So hospital stipends are also a significant source of income or revenue for the practice. And then some practices have other sources of income. They may have management fees for helping manage surgery centers or doing other kind of related type jobs. So the more entrepreneurial the practice is, the more you might see that they're bringing in other sources of revenue besides pro fees and stipends from the hospital. So those are the main sources of revenue for a practice. And whenever you see that the practice is receiving a significant stipend from the hospital, that means that hospital's paying big money. Usually it's millions of dollars. And so it's, the next question is, well, how secure is that revenue? And again, what is the practice doing to make sure that that revenue stays secure? Because anytime there's a seven-figure item on the hospital's budget, they're thinking about how can I get that number down or take it off entirely. So, if the hospital feels like they're getting value for that seven-figure number, then it's good, and it just means that you'll live another day to practice at that hospital. But it's always going to be a target, and so there's always going to be a need to demonstrate value to justify that money.
Yeah. One of the things I'm curious about is I've always been a hospital employee, or I've worked for a private group, but never for a group where I was going to be a partner in it. So at that point in time, I'm starting to think about, who's managing this money? How's that handled? Is that being outsourced? Is that within the group? What are the overhead costs? Because all these things are going to be affecting basically my bottom line down the line, as far as getting a salary and getting paid bonuses. What do you guys do?
Yeah, so almost all practices will outsource what we call revenue cycle management, the submission of bills to insurance companies, the collection of those fees. That's revenue cycle management. That typically runs somewhere between 5 and 9%. It's usually around 5, close to 5%. So there's going to be a cost right there for submitting bills, collecting the money, and then on top of that, there's going to be overhead for, sometimes you'll have schedulers who actually assign the cases. So some practices will have non-physician staff who are helping with the administrative functions of the practice, helping with credentialing, helping with, as I said, scheduling, helping with any number of other sundry kind of responsibilities that are needed to sustain a practice, especially a bigger practice. We have 2 schedulers in my practice. We have an administrator for my practice. We have a leadership team. We have the physician partners who are leaders for the practice, and the non-physician staff are salaried, benefited employees. The leaders within the group receive a stipend for their leadership work. And so, it's reasonable to ask, what is the actual overhead for the practice? And is it 20%? Is it 30%? I think that you'd like to see something around 20% or less. There are some practices that run very lean, that don't have any administrative staff, just rely on physician volunteers to do a lot of the work of a practice, and they're below 10%. So it can get very low if you want to be really lean. But I think the concern is that if the overhead is too high, at some point, the partners, the people who are doing the clinical work, are going to ask, why is X coming into the group and only 70% X is coming out and paying the people who are actually doing the work? So overhead is important. I think that if it's also reasonable to ask, who's actually doing the, some of the heavy lifting of the practice, who's contracting, developing contracts with insurance companies, who's developing contracts with hospitals and surgery centers, who's overseeing the billing company, the revenue cycle management company, to make sure that they're sufficiently doing their job to submit bills, collect the money on the practice's behalf. So that's a lot of hard work. And so if the physician leadership is doing all that, then certainly they need to be compensated for that, because that takes time out of the operating room. It takes away from the opportunity to earn revenue for your clinical work. And so it is important work, and it needs to be compensated. So I think that knowing what the overhead is important. Knowing how the overhead expenses are actually, how that money is actually being paid is important. So, excuse me for the dog in the back.
I have kids. I'm surprised we haven't heard them yet.
So anyway, I think that's maybe getting into the business of the practice a little bit more than you may want, but those are, I think, ultimately going to be reasonable questions, especially if you're going into a practice where you are being considered for being a partner or shareholder. But also equally important if you're an employee, because you want to make sure that your employer is stable and that things are done in a way that as much money that comes into the practice goes out to the people who are actually doing the work, the hard work of clinical care.
Mm-hmm. You just mentioned about becoming a partner. I guess let's start to talk a little bit about the structure of the group. How are some of these groups made up, and maybe what it entails as far as making a partner or how you're paid and all that.
Sure. So in my area, in the kind of San Francisco Bay Area, most of the independent anesthesia groups are comprised of partners or shareholders, that is, owners in the practice. And so that's one first question is, am I being considered for partnership within the practice? I'll be an owner of the practice, or am I an employee, a fully benefited employee? It's very different. As a partner, you do have the benefits of having say in the direction of the practice. You have a say in important decision making within the practice. But also means, and you have the opportunity to benefit from the profitability of the practice. You also have the opportunity to benefit or to experience the downside of the practice. So to the extent that the practice loses money or requires, if there's some sort of shortfall, if there's a legal situation and partners have to help cover legal costs for the practice, then that is something that is owned by the partners, the shareholders of the practice. As an employee, you're somewhat shielded from both the upside as well as the downside of the practice. So that's important, is am I an employee or am I being considered for partnership? And if, again, as I said, most the independent practices in my area are partnership track positions. And so the question it should be, what is the path to partnership? Is there a timeline? Is it a fixed timeline of 2 years or 4 years or 5 years? And are there defined metrics that will determine whether I become a partner or not? Or is it simply, well, you're eligible for partnership in 2 years, and we'll kind of see how it goes from there. If the business is looking a little bit sour, or there are some competitive threats in the market, does that mean that once I become eligible for partnership, simply those external business threats are going to prevent me from becoming a partner? Or is it going to be more structured, where as long as I meet certain criteria, certain performance standards, I know I'm going to become a partner despite kind of the external threats to the practice. So it should be structured and shouldn't be kind of fuzzy about whether a person becomes partner or not. I think it's reasonable to ask, for people who didn't become a partner, it's like, what were the reasons they didn't become a partner? I think it's reasonable to ask for, what is the attrition of the practice? Has this been stable? For those people who are in a partnership track but decide to leave, why did they decide to leave? Are there partners who actually left the practice? Why did somebody invest the time and energy to become a partner in the practice and then leave? So what is the attrition of the practice, both for those who are partnership track as well as those who become full partners? So I think those are reasonable questions to ask. That give you a better picture of how much and how well you're going to be supported once you join the practice.
All right, that sounds good. That's a lot of information. And Peter, I think at this point in time, why don't we wrap this up? I'd love to bring you back on. We've covered a lot of stuff already. We still have a lot of stuff to cover, such as how am I paid, what are benefits like, and most importantly, what is the culture of the group? Because that could be the big question at the very end of the day. How do you answer that? But I appreciate your time for today. We're definitely going to bring you back on. And until then, take care.
Thanks so much, Patrick. I enjoyed doing this.
All right, we'll see you soon. I hope you really enjoyed part 1 of our video with Dr. Peter and Jose. Now, there was a lot of information that was given us there, so I thought we'd just cut a little bit short. We're going to bring him back on. He's already agreed. So to make sure you don't miss part 2, hit the subscribe button for that video and any other videos we put out there. Hope it helps and good luck.